السلام عليكم. نبدأ second session. We'll start with Dr. Ali Sharifi. He will speak about the art of refraction and the contact lens overview.
Okay, I'll try that again. So first, thanks for the Kuwait Ophthalmological Society for inviting me. It's an honor to be among your esteemed guests. Today my talk is going to be two parts. The first one is going to be on the art of refraction, and the second is going to be on contact lens updates. And what actually I'd like to do, if possible, I want to start with the end of my discussion and begin with the beginning. So let's see if I can get this scrolled properly. No. Can I get some help with the scrolling of the slides? Okay, yeah, there you go. Okay, contact lenses, I think it's a really exciting time as an eye care practitioner to be able to see all these new and nice innovations that have been coming out in the last couple of years. I feel that there have been tremendous jumps in what we can do today, which weren't available only a few years ago. And I think I wanted to mention that one of the biggest ones that's been coming along has been this whole idea of what can we do to control myopia and how can we reduce progression. And this is something that's been in the works for the last at least 20 years. People have been trying different approaches to try to curb myopia progression. And they've noticed in the last, between 2000 and 2010, let's say, around that period, and maybe slightly before, slightly after, but in that decade, there was a large push towards finding spectacle corrections for myopia reduction or reduction progression. And those primarily stemmed with using flat-top executive bifocals or progressive addition lenses. And while those solutions gave some results, they started noticing that early on that with the advent of orthokeratology about 20 years ago, where you fit a rigid gas permeable lens on the cornea and have the patient sleeping in them overnight, they noticed that when this was done in children, that the axial length elongation that you would typically get in myopia was not happening as much as the average. And that kind of stuck in some researchers' ideas, and they wanted to know, why is that? Why is something that's placed on the surface of a cornea, why would that impact the effect of axial length elongation? So that was just, something that was kind of puzzling to them. And so that they kind of kept that in mind while they're doing other research projects and tried to figure out a solution for that. And let's say in the 2010s and beyond, there's a researcher by the name of Earl Smith who found that there's data that suggests that peripheral myopic defocus may reduce the progression of myopia. And they did some experiments on some monkeys, and what they found was that they fit them with these contact lenses that had center distance and surrounded by a ring or an annulus of a myopic defocus lens. Essentially what it is, it's just a bifocal contact lens. So a bifocal contact lens with a center that's clear, that's in focus at distance, surrounded by an annulus, a ring, let's say, or rings, depending on the design, that had small add powers. So that would induce a myopic defocus around those areas around the fovea. So the fovea is in focus for distance, the periphery slightly around it is in focus for near. So what it does is it imparts a myopically blurred image in front of that retina. And what they found was that these monkeys that they did this experiment on actually started developing hyperopia compared to a control group that only had a single vision contact lens on. And so they came up with this theory that perhaps this myopic defocus may be a solution to part of the problem. So in about 7 or 8 years ago, they tried this in children, so that they fit 2 groups of children, one with single vision contact lenses for distance, the second group with a bifocal contact lens, similar design, which is peripheral near, so central distance, peripheral near, or peripheral defocus, as they want to call it. And they followed them for 3 years. So CooperVision did this. There are some other manufacturers also doing this, but CooperVision, I guess, beat them to it. And what they found is that over a period of 3 years, axial elongation along with myopic increases were not as it did not increase as much as you would expect. The average myopic progression is about half a diopter a year, roughly. And what they found was that over a period of 3 years, a cumulative myopic progression in the patients that were fit with these bifocal contact lenses was that only increased by half a diopter over a period of total 3 years. And the control group, which had just a single vision contact lenses only, those increased to a diopter and a quarter. So that's a net difference of 0.75, which is significant. Okay. There was another study done by an unrelated group in Spain, and they wanted to see what would happen if we just do the same comparison with a bifocal contact lens, the same one, the MySight in this case, and single vision glasses, and again followed them over a period of about 3 years, and the same thing happened. The patients that were fit with single vision glasses developed more myopia, more, an increase in overall circle equivalent of myopia and an increase in axial length elongation, while the treatment group that had the bifocal contact lens did not. So this is really exciting. This contact lens came out, I think, around the 2020s. I think it got delayed for obvious reasons. But now it's becoming more and more accessible. It is not accessible, unfortunately, here for us in Kuwait. We tend to get things last, unfortunately, but it is available in Canada, the United States, East Asia. But while I'm at this, I don't like to go on tangents. I like to be focused. But I have to say that the same design is being used in spectacles now. It is hitting markets, I think, already in the US and maybe Canada, and I think in East Asia. The same design, but in the spectacles. Okay, so there are I think there are 2 or 3 different companies that are producing it. One is Hoya. They're using a lens that's using a technology called DIMS, and what it does, it has again a center area that's clear and surrounded by a peripheral ring of like lens or an island of lenses that have like a defocus of a +3, which aims to do the same thing as what this type of contact lens does. So you can do the same approach, but in spectacles, because I might not be able to fit all my kids in contact lenses. There's an issue of infection, and there's an issue of maybe poor use, insertion, removal. So glasses can do the same thing. And the studies that they've done on those also show a similar type of result. Now, we don't have any FDA-approved spectacle lens technology that will reduce myopia, or that's shown to reduce myopic progression, but I bet that's probably in the works. It'll probably happen over the next few years if the data holds up, and it seems to. So I think that's a really exciting time to be an eye care professional. There's something you can do that we couldn't do in the past. So CooperVision MySight one day, that's an interesting product. While I'm at it, I guess everybody's heard of the LAMP studies with the atropine of studies with a 0.05, 0.1, and 0.15. So that's another approach. If you don't want to use contact lenses and you don't want to use glasses, you can use a atropine that's been reduced in concentration, and that's another approach that people are taking in the U.S. and in East Asia and in Europe. So we have more than one thing you can do if you want to prevent your young kids from increasing in myopia. So contact lenses, if it's available in your market, this will be available in most markets probably this year or early next year. You can do the defocus incorporated glasses, which will do the same thing. There's one from Hoya, there's one from Essilor, there's one coming from Zeiss. I'm sure Nikon will have one. This will probably be all launching, at least in our region, in the Middle East, probably sometime this year, inshallah. Okay, so you can do that. You can do atropine. If none of those are available, what can you do? Bifocal glasses, executive bifocal glasses, progressives. Those are your last option. They don't give the same results that these do, but it is better than nothing, and that's something worth consider. Okay, so that's one. That's the kind of the design that they have. And when I was talking about having these rings of alternating between distance and near, this is kind of what they're looking like. So the center is clear, surrounded by a periphery of plus power, and then it alternates. And the spectacles are almost the same design, slightly different, but it's a similar concept. So peripheral myopic defocus may retard the progression of myopia. So that's one. Okay. This just goes over the studies and the results. So there's a new class of drugs, of contact lenses, and this is the first time that we have an FDA-approved contact lens that's actually medicated. So this is a antihistamine eye drop. Ketotifen, this is called Zatador in many markets, and you might be familiar, it's been around for 20 years, very safe. And it's a triple-acting drug with an H1 blocker along with a mast cell stabilizer, and it also tends to reduce inflammatory cells from accumulation. And so they decided to make a one-day contact lens in patients that have allergies with contacts and soak it in an antihistamine. So I don't know, I think for this approach it's interesting. They went with a safe drug. I guess it's like you're going to the McDonald's and you're ordering a burger and you get like a statin drug with it. So it's like if you maybe reduce your contact lens wear, maybe you won't have as bad allergies. I don't know, it's one or the other. There's also a artificial tear with ketotifen, sustained with Zatador. So that's something, that's unrelated, but I saw it, I thought it might interest some people. This lens I think is probably really interesting. It's active oasis with transitions. For many years people have asked me, why can't we get transitions, photochromic lenses like we can in our glasses, why can't we get those in contact lenses? And in fact they were able to do this. This launched I think right before COVID, I think in 2019, and it's been available in the market. It's been available here in Kuwait, but most people are unaware of it. So this is active oasis is a 1 to 2 week replacement lens, and it's very safe. It's one of those new ones with hyper decay characteristics, and what this lens does with transitions is about 15%, has a 15% tint, and it increases along with UV exposure, and can go to about 70% light transmission after being exposed for a short amount of time with a specific type of wavelength. I think if you have dark eye irides like we have most of us here in the Middle East and Asia, it's not going to be an issue. But if you're like Dr. Eye Health here from YouTube, and you have one light eye, if you have light eyes, this will make your eyes definitely darker. So you should be aware of that if you're practicing in Europe or if you have patients that have light irides. So that's that. And now I'd like to go to the beginning of my lecture, which will be my end of my lecture. And we will discuss the art of refraction. Let's go, there we go. Okay, so is a refraction an art and a science? And in fact, I would say yes to both. The goal of a refraction is simply to get all the light rays focused properly on the retina, and that's very simple in terms of doing it on paper. Unfortunately, many times we give the patient the best refraction we can, only to have them come back to the office in a couple days, or maybe even if you have that like the same day, complaining about asthenopia, blurred vision, even double vision. So first of all, as far as the refraction is concerned, how variable is it? So if I was going to take the same practitioner with the same patient and redo the refraction over a period of like 10 times, how repeatable is this? And the old textbooks show that it's normally like 80% of the time it's repeatable within a quarter of a diopter, and within half a diopter for 90% of the time. So repeatability, there is some variability in this, but we do have different studies that show different ranges of rejection of or non-tolerance of a spectacle RX, and the majority of the time it's due to an incorrect refraction, And some of the time it's due to a correct refraction, but the patient just cannot tolerate it. And about, let's say, 20% of the time, it's due to a dispensing non-tolerance. So when in research, when they're talking about dispensing non-tolerance, they're talking about perhaps the glasses, optical center is not sitting directly in front of the patient's pupils. They may be talking about the tilt of the frame in respect to the face, so the tilt of the lens, and that's called pantoscopic tilt, and it can be tilted away from the cheek, that's called retroscopic tilt. If it's tilted towards the cheek, that's called pantoscopic tilt. It can also due to something called face form wrap and how the spectacles wrap around your face, so that angle. So there are different levels of, let's say, error that can be introduced, and even with a correct prescription that can lead to the patient being unhappy or unable to tolerate their spectacles. So,
just 1 minute.
Yes, go ahead. Okay? Okay, sure. Okay. There was a study from Canada that showed they researched 25,000 patients and found from those 25,000 patients, they had 400 patients come back with non-tolerance. So that was by Dr. Herncheck and her group at the University of Waterloo in Canada. So there's a failure to accept glasses about 1.6%. And a similar study from the UK, from Freeman and Evans, found that their, on average, spectacle non-tolerance varied from 1.3 to 3%, and that's also very similar to results from Canada. And there's another group from India with a tertiary group, and they found, actually, I found this impressive, 0.5% non-tolerance to spectacles, and they had the largest subgroup. They had almost 170,000 patients whom they prescribed for over a period of several years, and they found that only, let's say, almost 800 patients came back. So there is some variability in terms of spectacle non-tolerance. Somebody researched, like in the 80s, or 90s, they researched in terms of the manufacturing labs, the labs that service the optical shops, to find out how many spectacles get remade. And they had an estimate about 5%. Now, I worked in the hospital setting. I also worked in an optical setting, in an optical shop setting. I can tell you 5% is probably closer to the truth for spectacle rejection, but that includes problems with dispensing and refraction. So if they may not be able to, in that research that they had done that showed 5%, they may not have been able to separate if it was a refractive error issue, the prescription was just wrong, was it the prescription right with the patient was just unable to tolerate it, or was were the spectacles, the design, maybe it's a multifocal, maybe it's a bifocal, was there an issue just adapting to that design? So that study wasn't able to give you the fine details, but 5% sounds a lot more reasonable in terms of rejection of spectacles. Let's go to the next one. So Herncheck over in Canada, she found that 60% of the time the cause of rejection of glasses are inaccurate prescriptions. And only 10% of the time was the prescription accurate, but the patient was not able to adjust. And a similar finding was also in the UK. They found that 61% of the time the patients were not able to adjust because the prescription was wrong. And 22% of the time it was due to dispensing related. So dispensing related, again, maybe the optical centers weren't perfectly lined up. Maybe it was a multifocal or a bifocal spectacles and the seg heights were inappropriate. Sometimes it can be, dispensing problems can be something as simple as communication. You have a new progressive wear, a new bifocal wear, and they don't know what they're supposed to be doing. And they think that maybe that their bifocals will be able to allow them to see the computer screen, when in fact maybe they're stuck at 40 centimeters or infinity and there's nothing in the middle. Or maybe they're getting progressive lenses and they may be really observant of the peripheral distortions that they may be getting because of an induced meridional stigmatism maybe that's coming from the sides. So these types of problems occur and they're all lumped under dispensing problems. And an important finding by Friedman and Evans, they found that the majority of the spectacle non-tolerance came from presbyopes. And I guess that's logical, right? I mean, they have to worry about more than one focal distance, so there are multiple issues that can cause a pair of glasses to fail.
Dr. Ali, you may conclude, please.
I'm sorry, but I don't have
You may conclude, because
Okay, I'm sorry, out of time. Okay, so to conclude, basically, if you have a new patient that's not tolerant of the glasses, make sure they're first made properly. If they are, most likely it's because of a large change in refractive error that they may have induced. Maybe they just had cataract surgery, and looking through their glasses, they have two unequal image sizes, so they're suffering from anisoconia. And to reduce this problem, the best way to do it is demo the prescription that you think the patient could accept in a trial frame, and have them walk around, have them looking down the hallway. Try to read their body language. Try to listen what the patient's trying to say. Most likely you'll have to reduce the prescription. And the goal of a successful refraction is not 20/20, it's 20 happy. Okay, that's it. Thank you.
Thank you. Professor Ahmed Assaf, we want to know his experience in managing posterior capsular tear during phacoemulsification.
Good morning. Thank you very much for the invitation. I would like to thank the organizing committee and Dr. Faisal Al-Jassar for their invitation to attend this meeting. I've been invited maybe for the first time in late 90s by my dearest friend, Dr. Sami Rabia, and I was amazed by the level of their knowledge and the hospitality I witnessed at that time. So at this time, you raised the bar even more, so I'm truly fascinated by this meeting, and thank you very much. Thank you for everything. So can you bring my slides, please? First one, please. Just scroll up to the first one. Yes. Start the play. Sorry, because I don't have the control on my presentation. So I'd like to share with you my top 5 peers in management of open posterior capsule. Next slide, please. And as you know that back to the anatomy, the eye is divided into anterior segment and the posterior segment, and the barrier between both is the posterior capsule together with the anterior hyaloid. So as long as the anterior hyaloid, I have no control on this. Okay, so as long as we have here the barrier between the anterior and posterior segments with the posterior capsule and the anterior hyaloid. During phacoemulsification, if there is, you should keep the barrier intact between the anterior and posterior segment during phacoemulsification. In case of open posterior capsule or lost the barrier between the anterior and posterior segments of the eye, here you will get vitreous prolapse inside the anterior chamber, and you may end with some lens matter fall down in the posterior segment of the eye, complicates your surgery, and the vitreous might be prolapse, and aspiration while doing irrigation aspiration or continuing phacoemulsification, aspiration of the vitreous will stress on the vitreous base and may cause retinal breaks, and even if you pull out the phaco handpiece, you may initiate a giant retinal tear. So here, I would like to share you my stepwise approach for management of open posterior capsule. Next, please. So this is for example, for the first time, if you just notice a break in the posterior capsule, just freeze. Stop doing everything. Remove your foot in position 0, as you can see in the right side of the screen, and then stop phacoemulsification, stop everything, stop irrigation, and inject OVDs inside the anterior chamber. It's mandatory to inject dispersive OVD, but if the dispersive OVD, like Viscota, I don't have any financial interest. If the dispersive OVD is not available at your hand, you can inject any OVD inside the anterior chamber. The idea here is to pressurize the anterior chamber and prevent further prolapse of the vitreous inside the anterior anterior chamber. Next slide, please. Again, you should stain to make sure there is no vitreous inside the anterior chamber. Don't count on your expertise, because sometimes the vitreous is transparent, the vitreous is, you cannot see the vitreous unless you throw some triamcinolone acetate on the, inside the anterior chamber. Here, I'm just using diluted triamcinolone acetate. You can dilute it 50-50. Next, please. Or you can just prepare it by 1:9, and this is how we prepare the triamcinolone acetate. We don't have the available preservative-free triamcinolone acetate to be injected inside the eye, so we can do it, prepare it ourselves with the regular or standard Kinacort or triamcinolone acetate. As you can see here, there is a prolapse of the vitreous through the main incision, and we can never see this vitreous knuckle prolapsing inside the anterior chamber toward the main incision, driven by the pressure gradient, unless we stain the vitreous with triamcinolone acetate. So again, please, this is mandatory. Next slide, please. And don't forget, just before conclusion of the surgery, you have to stain the vitreous again to make sure there is no vitreous before conclusion of the surgery. You won't be very happy if you have some vitreous knuckle prolapsed to the main incision on the first post-operative day while examining the patient on slit lamp, and you find that the pupil is drawn up or there is vitreous prolapsed because it acts as a conduit for endophthalmites. So again, you have to stain the vitreous and the anterior chamber before conclusion of the surgery and before leaving the patient. Next slide, please. And if you are going to do vitrectomy, you have to do through a closed system. I see many fellows doing vitrectomy through the main incision, which is it's not the right way to do the vitrectomy. So here, I prefer to use the pars plana approach for anterior vitrectomy. Thanks to the 23-gauge trocar and cannula system, we don't have to do sclerotomies, we don't have to do conjunctival dissection, so we can just do pars plana anterior vitrectomy, and I think every anterior segment surgeon can do this approach. Next slide, please. If you don't have the trocar, 23-gauge system trocar and cannula, so still you can use the standard methods for anterior vitrectomy. I just do the sclerotomies 3.5 millimeter from the limbus. Again, you can never see vitreous unless you stain it, and the idea here with pars plana approach that you can pull back the vitreous from the anterior chamber back to the posterior segment of the eye. Next, please. And again, if you can see here, you can do the limbal approach, anterior vitrectomy through the limbus. If you are not very confident with the pars plana approach, you can do it through the limbus. Here, I'm doing just dry vitrectomy to amputate this vitreous knuckle and push the rest back to the anterior chamber of the eye, close the main incision with temporary suture, and then use 2 paracenteses to do the vitrectomy. Never do the anterior vitrectomy through the main incision, otherwise you will invite more vitreous by the pressure gradient, and you will end up maybe with stress on the vitreous base or hypotenuse eye because you are overdoing vitrectomy through an open system, not closed system. Next slide, please. And period number 4 is once you start vitrectomy, you have to use the highest cutting rate available with your phaco platform. It differs according to the phaco platform, but the rule of thumb is to start with the highest cutting rate because this ensures smooth vitrectomy for the vitreous prolapse inside the anterior chamber. You may switch sometimes to irrigation, aspiration, cut, irrigation, cut, aspiration, according to whatever you are going to remove. If you have some cortex and after removing the vitreous, we can switch to vitrectomy mode, irrigation, aspiration, cut, and here it acts as an irrigation aspiration, then cut any vitreous knuckle that intervene between the cortex and the vitrector probe. Next slide, please. Again, this is how we do it. You can see this is the highest cutting rate of 4,000 cuts per minute, and this ensures, as you can see here, ensures smooth vitrectomy. Again, you will never see vitreous unless you stain it. You can do the vitreous vitrectomy after implantation of the 3-piece. This is the scaffold technique that I'm going to present later on. in the next movie session. And here we can switch here between irrigation. This is irrigation aspiration cut. This is just to remove the cortex. You can see that some of the cortex still present in the capsular fornices, so we can deactivate the cutting and then we can irrigate, do some irrigation aspiration to remove the cutting and then continue again for the highest cutting rate. Next slide, please. And pure number 5 is the safest to implant. The lens is 3-piece lens. You can implant single-piece lens inside the capsular bag as long as you have enough capsular support from the posterior capsule, but the safest here is to implant a 3-piece lens in the sulcus. There are several ways to implant a 3-piece lens in the sulcus. You can implant it directly into the sulcus, or you can just implant the lens inside the anterior chamber, and then you can do some dialing if you have clear vision with the large pupil. As you can see in this case, you can just dial the lens to put the haptics into the sulcus, or you can sometimes flex each haptic at a time with a Sinskey hook or a Coughlin hook to bring the lens into the haptics into the sulcus. Here I'm doing the optic capture, and this is mandatory to have the excellent stability of the 3-piece lens. And by doing the optic capture, just pushing the optic of the lens back into the capsular bag underneath the capsular axis. And this way, as you can see, the capsular axis turns to elliptical rather than rounded appearance, and this denotes successful optic capture. In this way, the optic of the lens is almost inside the capsular bag behind the rexus, while the haptics are in the sulcus, and this ensures stability of the lens, because in many cases the sulcus diameter may be large, more than the 13.5 millimeter, the overall diameter of the 3-piece lens. Next slide, please. Again, this is another way. You can just implant the lens directly inside the anterior chamber. And of course, you should keep the 3-piece lens as a backup lens in the OR, just in case of open posterior capsule. So if you are going to implant a single-piece lens, you have to prepare another 3-piece lens almost with the same power, or maybe 0.5 diopter less, just in case of you have an open posterior capsule. Again, this way, because the pupil is not very well dilated, I was not sure that dialing the lens will bring the haptics to the sulcus, so we can just flex the haptic and put each haptic at a time into the sulcus, and never forget to do the optic capture, because this ensures the stability of the lens. And even you don't have to change the power of the lens, because the optic of the lens is almost in the same level as if the lens has been implanted inside the lens capsule or in the bag. Next, please. So in conclusion, my top 5 peers: just freeze and inject OVD once you notice a posterior capsule break. Stain with diluted triamcinolone acetate. My recommendation is 1:9 ratio. Do pars plana or anterior or limbal approach anterior vitrectomy, but should be in a closed system, so you have to close your main incision if you are going to use the limbal approach. Start with the highest cutting rate of vitrectomy cutter available on your phaco platform, and prepare the 3-piece lens as a backup lens to be implanted in cases of open posterior capsule without enough capsular support that will hold the single-piece lens. Thank you very much for your attention.
Thank you, Dr. Asaf. Now, the next speaker will be Dr. Turki, speaking about preoperative evaluation of patient with cataract.
Assalamu alaikum. So I will be talking about the preoperative evaluation of cataract surgery. I have no financial interest. So as an introduction, many surgeons now can prevent or anticipate or decrease the complication with careful planning. So we have to evaluate the patient in preoperative, usually starting with the history, examination, and investigation. So starting with the history, usually we will start with the patient age, based on the patient age, we can determine the visual demand of the patient and target the post-operative spherical equivalent and the type of anesthesia. For example, in young patient, usually they cannot tolerate local anesthesia. So moving to the history, we will start with the comorbidities of ocular comorbidities like glaucoma. And glaucoma, usually you have to control the intraocular pressure before going for elective cataract surgery and try to avoid superior ACC. If advanced or on maximum anti-glaucoma medication, think about combined surgery. For patients with uveitis, the uveitis has to be controlled prior to the cataract surgery, and you might need pre or intra and post-operative steroid. Ask about previous refractive surgery, because to avoid any IOL calculation error. Ask about previous retina surgery or intravitreal injection, which can result in BCR or violated posterior capsule. Ask about history of squint for patients, because some of them, they will have post-operative diplopia. Regarding the ocular history also, you have to know if this is the first or the second eye, because for the second eye, usually we prefer to use the same IOL and counsel the patient about monovision. For patients with diabetes, usually they tend to have less corneal endothelial integrity than normal population. They have poor dilation, and dilated fundus exam with macular OCT, it's a must for them. Patients with poorly controlled diabetes are not good candidate for trifocal IOL, although this is controversial. Patients with rheumatoid, usually we should optimize the rheumatoid arthritis before going for any intraocular surgery to avoid complication like melting. And patients using hydroxychloroquine, the surgeon should evaluate the macula carefully prior to the cataract surgery. Patient with Parkinson, assure the patient that he will use his medication and continue to use it throughout the day of surgery. If tremor is significant, consider general anesthesia. Superior approach is the preferred surgical approach. Patient using selective alpha-1 antagonist medication, these medications can result in permanent sphincter muscle atrophy, which in turn results in IFIS, or intraoperative floppy iris syndrome. And the classical triad of IFIS is floppiness of the iris, progressive intraoperative meiosis. So usually you will start with reasonable dilation, and in the middle of the surgery you will have very poor dilation and limited view to the cataract. The third is the iris prolapse through the surgical wound. Moving to the examination, we should check the vision with and without spectacles. For me, I'm doing preoperative refraction for all patients. Why? To rule out any refractive error as a cause of decreased vision, to be correlated with the cataract density as a cause of decreased vision, also to be correlated with the axial length and K readings. For example, if the axial length is normal and the K readings is normal or within the normal range, and the patient has high myopia, think about zonulopathy like microspherophakia. For example, if the axial length is 23 and K readings is 43, but the patient is -15, so think about lenticular. The fourth is to assess the need for sequential cataract surgery. For example, if the patient has high myopia, -10 in both eyes, so you have to counsel the patient about the fellow eye, whether to use contact lens or to go for sequential cataract surgery. Because sometimes if the patient has high myopia and he underwent pars plana vitrectomy after the surgery, after the first surgery, the patient will not be satisfied if you ask him to go for the second eye because of high risk of retinal detachment. Also, before doing cataract surgery for the second eye, to avoid anisometropia. Check the relative afferent pupillary defect, extraocular motility, intraocular pressure. Rule out nasolacrimal duct obstruction, and if there is nasolacrimal duct obstruction, DCR should be done prior to the cataract surgery to minimize the risk of endophthalmitis. Also check for blepharitis to minimize the risk of endophthalmitis. Cornea, we check for severe dryness, because severe dryness can affect the IOL calculation. Corneal opacity, which can limit the view to the cataract, and distant endothelial abnormality. Anterior chamber, we have to check the depth and reaction. Regarding the pupil lens and zonules, check the pupillary dilatation and check the density and type of cataract. For example, patients with anterior lenticonus at higher risk of anterior capsule extension if you start at the area of lenticonus during capsular excess. Patients with posterior polar cataract at risk of posterior capsule rupture, so we have to avoid the hydrodissection and check the zonules and lens size. if the size of the lens is very small, so we have to think about zonulopathy or microspherophakia. Also retina and optic nerve to rule out any retinal or optic nerve abnormality. Regarding the investigation, usually I'm doing the corneal tomography for all patients. Why? Because sometimes when we do IOL calculation, the biometry device will not tell you about if there is irregularity or ectasia. So, and this irregularity or ectasia can result in inaccurate IOL calculation, also to check the amount of astigmatism and its access for toric IOL. So without corneal tomography, we cannot go for toric IOL. To rule out any previous corneal-based refractive surgery, and for IOL calculation for patients post-refractive surgery, to assess the amount of corneal spherical aberration which might affect the selection of your aspheric IOLs. Specular microscopy is an non-invasive diagnostic modality to image the corneal endothelium, and usually we will check the morphology and the cell count. Starting with the morphology, we have to check the hexagonality, and if there is significant polymorphism, which is different shape, the hexagonality will be less than 50. Regarding polymorphism, it is the first sign of endothelial disease, so it will appear and it will be abnormal before having low cell count, and it is abnormal if it is more than 40%. Regarding the cell count, these are the normal values for each age, and also we have to check the inter-eye difference. It should be less than 280. Retinal assessment, including macular OCT as a part of retinal exam, and if there is no view, request B-scan. Moving to the next talk, which is about IOL calculation for general ophthalmologists. Usually we have to try, when we select the IOL power for the patient, we have to ask the patient about his visual demand, occupation, and we have to avoid high anisometropia. So we want to achieve minimal refractive error if the patient, he wants the far vision, and we have to keep in mind the fusion of the patient. So that's why we have to avoid anisometropia. Also, we have to tell the patient if he is not good candidate for premium IOL about monovision. So before we start the IOL calculation, usually we are using for IOL calculation the average K, which is the K1 plus K2 divided by 2. And here, this is the target post-operative spherical equivalent. Some surgeons, they think that this is post-op sphere, but this is spherical equivalent. This is the attempt or the target. So let's say we used 8.5 IOL power, and we aim for minus 0.53. So this patient will see sharpest image, 20/20, at 188 centimeter. So this is the way that we calculate and match the IOL power to the patient demand. The axial length, we can measure the axial length using ultrasound, whether by contact or immersion biometry, or by optical devices like IOL Master, LensStar, and others. So the optical is more accurate, and it measures up to the axial length up to the RBE, unlike the ultrasound, which measures up to the ILM. And if we measure up to the ILM, the axial length measurement is affected by corneal edema. And if we use ultrasound, sometimes we have false short axial length, which induce myopia or myopic error because of aggressive corneal indentation, dense cataract, and hypotony. However, for a false long axial length, which can result in hyperopia, the most common example is silicone oil. That's why we have to adjust and make sure that the velocity of the ultrasound is adjusted when we measure the axial length in patient with status post, let's say, silicone oil. IOL constant. Some they call it IOL variables. Okay, so for different formulas, we have different constants. For example, SRKT, we use A constant. For Holiday one, we use surgeon factor. For, let's say, Olsen C constant. So let's say we will use IOLX, and we will calculate the power using SRKT and Holiday one. So for SRKT, we use A constant, and we have two A constant for each IOL. We have the A constant if you measure the axial length using ultrasound, or if you use optical. And if we go back and calculate the power using Holiday, we will use something called surgeon factor, or SF. And also surgeon factor, we have two surgeon factors. So for each IOL, we have if we use SRKT and Holiday, we have 4 constants based on the axial length measurement that you are using. And this is the baseline. That's why some will call it variable, because you can optimize it based on the results of your cases. So this is just a baseline. This is from the company. For example, this patient, as mentioned there, it is or highlighted there, it's they used SRKT, and here, for the right eye, for example, I have no financial interest, but IQ, it's mentioned that the A constant is 118.7. However, down, the thickness is 119.3. But in the measurement or the calculation, they used A constant, which is 118.8 down there. So you have to make sure that for SRKT, the A constant that we are using is the one highlighted, but the other one is just the name of the IOL. And here we have SF, which is surgeon factor, so here we are using a Holiday one to calculate the IOL power. And if you want to know the A constant, whether ultrasound or optical or other constants for your IOL, you can go to this website. You will find all the IOLs listed, and you can get the constant that you need. Okay, IOL power and position. When we try to implant the IOL in the sulcus, we have to reduce the power. But by how much? There is a table from the American Academy that depends on the power. We have to reduce the power of the IOL. For example, if you will use 27, you have to reduce it by 1.5 or 2 if you will implant it in the sulcus. But you can go to this website and you will find a table for each power, how much you should decrease if you will implant it in the sulcus. IOL formulas. We have different IOL formulas and different techniques to measure or to calculate it. We have historical, regression, vergence, artificial intelligence, ray tracing, and hybrid. And the regression alone and historical are obsolete. And these are examples for each IOL. And regarding the vergence, we have 2 variable formulas. We have 3 variables, 5 variables, 7 variables. So why is this important? Because sometimes you will go to their website to calculate the IOL, but you will notice at the end that you don't have, let's say, lens thickness. So in Barrett, it is optional and the white. But if you want to have the calculation using Barrett and you filling all the parameters that they needed, you have to get the lens thickness and white. Okay, thank you.
Thank you, Dr. Turki. Very nice presentation. Now, next lecture will be by Dr. Ahmed Assaf, ectopia lentis and IOL exchange.
Thank you very much. Actually, both are very complex subjects, so I divided into 2 small videos just to highlight some of the issues with the ectopia lentis and the IOL exchange. So we'll start with the ectopia lentis. Can you bring up my slides, please? As you know, there are a variety of reasons for ectopia lentis. It might be zonulopathies like Marfan syndrome, Wein-Marchesani syndrome, homocystinuria, or maybe sometimes because of traumatic. So here, yes. So because of the COVID times, we have limited supplies of the iris hook, of the capsular hooks and capsular tension rings. So we faced some issues with the ectopia lentis cases, and I would like to share with you this case of ectopia lentis. As you can see, This is a 42-year-old female with Marfan syndrome, and it comes with corrected distant visual acuity of 0.2 with -15 diopter of myopia. Nuclear 3 cataract, there are some zonular deficiency, as you can see, and at that time, in the COVID time, we have a very limited supply of the capsular tension rings and the capsular hooks. And even there is no capsular tension segment. So how to deal with this case? I started by placing infusion cannula in the pars plana, 3.5 millimeter in the inferior limbus, 2 paracentesis and another 1 paracentesis, and this is dispersive OVD trying to stabilize things inside the anterior chamber. Now, of course, puncturing the anterior capsule is not that easy, so we can use some sharp instruments like MVR or keratome 1.2 millimeter to puncture the anterior capsule, and this is the microexis forceps to execute capsulorhexis. Here I'm not caring about the centration of the capsulorhexis or even the size of the capsulorhexis. I'm just doing capsulorhexis to do phacoemulsification through and to prolapse the nucleus, as you can see in this case, because this is a way to bypass the issues that we have. This is a viscodissection to trying to dissect the nucleus. This is nuclear 3 into cataract into the anterior chamber, and this is the scaffold technique. Now, after prolapsing the nucleus inside the anterior chamber, I implanted the 3-piece lens of the correct power according to the biometry inside the anterior chamber. I'm counting on this lens to act as a scaffold to prevent things from falling down inside the posterior segment of the eye while doing phacoemulsification. So now I'm going to do phacoemulsification into the anterior chamber. As you can see, I have lowered the IOP or lowered the irrigation, lowered the dynamics in form of the aspiration as well as the vacuum and the ultrasound. I'm using, this is a fast forward part of the surgery just to show you that I'm doing some kind of slow motion phacoemulsification. And as you can see, the lens as a scaffold to protect things from falling down. And then after finishing with the nucleus, inject again dispersive OVD, never to allow the anterior chamber to collapse. And then with the vitrector, we can play around by doing irrigation aspiration for the cortical fibers, and we can do, of course, vitrectomy if there is any vitreous prolapse. Luckily, at that time, we didn't have any vitreous prolapse into the anterior chamber or inside the capsular bag. So why I'm preserving the capsular bag so far? This is just to prevent things from falling down. And again, there are some subincisional cortex adherent to the capsular fornices. We can just remove it, and then we can just simply remove the whole capsule, because I cannot count on this capsule even in the future, because this is a progressive pathology. The zonulopathy might extend. If I'm going to implant the lens without capsule tension ring, the lens capsule complex most probably will fall down in the posterior segment of the eye after a few years after the primary surgery. So what we have now, aphakia. Luckily, we don't have vitreous prolapse inside the anterior chamber, and the lens inside the anterior chamber, 3-piece lens. What I'm going to do with this lens, of course, I'm going to fix the lens to the sclera. There are many ways to fix the lens into the sclera, like the glued technique published by Amara Grawar, or the Yamani technique or intrascleral haptic fixation technique with the flange haptics. This is the fixation device that I'm currently using with the Yamani technique, that we don't have to do some marks on the cornea. It saves time and saves effort and ensure better centration of the lens. And this is the 27 gauge needle, or sorry, 27 gauge needle. We don't have the 30 gauge hypodermic needle in our area. And this is the 3-piece lens with the PMMA haptic. You have to be very careful because the PMMA haptic are very fragile and liable to be kinked during the Yamani technique. First, externalization of the first haptic, while leaving the needle inside the other needle inside the eye, and then externalize the second haptic and doing the flange, and now we have more or less a good centration of the lens. Again, don't forget to stain, just maybe because if there is a disruption of the anterior hyaloid face, you might end with some vitreous inside the anterior chamber, so you have to make sure there is no vitreous, and again ensure the centration of the lens, injection of some pupil constricting agent, removal of the trocar, 23 trocar, and we are done with the surgery without the use of capsule tension segment or the capsule tension ring because of the COVID time. And the patient was happy with the corrected distant visual acuity of 0.9. I target low myopia because she was a teacher and she preferred to read without glasses. And thank you very much for your attention.
Thank you, Dr. Ahmed. While the next video will show, regarding the sclerofixation, now what is your best type of sclerofixation in young patients?
I still prefer the Yamani technique. I used to do the glued IOL technique, but I prefer the Yamani technique. I feel it's more elegant for the patient and for the surgeon as well. So this is again another presentation for the IOL explantation. So let's start here. So this is a case of a 52 years old male patient presented with diminution of vision after phaco 3 weeks back. And the patient presented with red eye, dull aching pain, and he was on topical prednisolone and non-steroidal anti-inflammatory drugs. As you can see here, the lens, there are single-piece lens, most probably inside the sulcus. And this is, again, this is my message to you that never implant a single-piece lens in the sulcus, otherwise you will end with UGH syndrome or AX syndrome with uveitis, glaucoma, hyphemia. So as you can see, the eye is very angry, and the single-piece lens decentered inside the sulcus, and probably this is the source of inflammation and the patient dissatisfaction. So here we started the surgery trying to explant this lens. This is a single piece lens. You can see this, the lens is decentered, and started here with the paracentesis, one paracentesis, and the other paracentesis, injection of dispersive OVD to protect the corneal endothelium during explantation of this lens. And while trying to remove this lens into the anterior chamber, I found a lot of cortical matter still there inside the capsular, or the remnant of the capsular bag. So again, this is another source of inflammation because there are too much cortex left behind the lens, and probably not only the lens inside the anterior the sulcus, but also because of the huge amount of the cortex present in the remnant of the capsular bag. So this is a 3mm incision, and this is my preferred way for explantation of the lens, the Bachmann technique. Just cut the lens through the optic halfway, and then we can rotate the lens through the 3mm incision to explant the lens outside the eye. Why I didn't cut the lens into two pieces? Because the 3 pieces inside the eye on top of open posterior capsule might end with some of those pieces on the macula. So I prefer to remove the lens as one piece with the Bachmann technique. Again, as I mentioned in the previous presentation, start with the highest cutting rate, trying to remove all the vitreous from being prolapsed inside the anterior chamber, and then we can switch to irrigation aspiration cut, or we can deactivate the vitrectomy, trying to aspirate those cortical fibers. As you can see, the pupil is getting down, and it's not the best pupil to work through, but with the second instrument you can push back the iris to explore the area of interest while aspirating the vitreous from the cortex from the remnant of the capsular bag. So I just used the limbal approach. In this case, I didn't use the pars plana approach. Why? Because we have too much cortex. With the pars plana approach, you might end up with bringing those cortical fibers into the posterior segment, and I'm not sure at that time that I can catch all those fibers before falling down on the retina. So dealing with something related to the anterior segment of the eye, like the fluffy cortical fibers, I prefer to use the limbal approach to bring those fibers back to the anterior chamber and remove those fibers before falling falling down into the posterior segment of the eye. So you can switch between pars plana approach and limbal approach according to your decision or according to your preference. But in this case in particular, because of too much cortical fibers, I prefer the limbal approach to bring those cortical fibers back to the anterior chamber. And as you can see, there is no cutting here. This is just irrigation, and then we can activate cutting to remove those fibers of the cortex together with the vitreous, if there is any vitreous comes with the cortex. So we can activate and deactivate the cutting of the vitreous, and of course we should use, as I mentioned many times, the highest cutting rate of the vitreous, 4,000 cuts per minute. And after finishing the removal of the vitreous together with the cortical fibers, you have to check if there is no cortex left behind, otherwise we'll end up with inflammation. Then we can inject OVDs again. Make sure there is no vitreous and there is no cortex. Again, there are some cortex here. We can address these cortical fibers and then implant the lens, three-piece lens inside the anterior chamber. So far, because I had an intact rhexis, so I plan to implant the lens inside the sulcus. As long as the rhexis is intact and we have good remnants of the anterior capsule and the zonules are intact, so why not to implant the lens inside the sulcus? And so as you can see here, just flexing the haptic, the first haptic, to bring the haptic underneath the iris into the sulcus. And I'm doing the same with the Sinskey or Coughlin hook, just to flex the haptic. I prefer not to dial the lens in this case of mid-dilated pupil, because you are not sure where the haptic is going to be while dilating the lens. So just making sure that the lens is in the sulcus. Of course, there are some bleeding because of the uveitis, the long-term uveitis, or for 3 weeks after the primary surgery. It's very much expected. And then after making sure that the lens is pretty well centered in the sulcus, we can do the optic capture. Here, I'm just injecting OVDs and then pushing the optic of the lens one side to be underneath the rhexis, the other one again to be underneath the rhexis, so the whole optic of the lens now becomes behind the rhexis while the haptics are still in the sulcus. The difference between the three-piece lens and the single-piece lens, that the haptics of the three-piece lens are made of PMMA, they are thinner, they are less irritant to the iris compared to the single-piece lens. Again, before conclusion of the surgery, injection of diluted triamcinolone acetate, irrigation aspiration for the remnant of the OVDs, and prefer to close the main incision just with one stitch as a safety suture before leaving the patient behind. So this is one case. Can I have time for another case? Is it okay or not?
It's okay. How long it takes?
5 minutes. 5 minutes.
Okay, if you make it 3 minutes.
Okay.
Thank you.
Okay, this is another case of 28-year-old male patient with history of traumatic cataract 16 years back, managed by cataract extraction and IOL implantation, and he presented with sudden diminution of vision due to the dislocation of the lens in the mid-vitreous cavity. Here you can see this is the lens. It tends to be a PMMA lens because the time of the surgery maybe 16 years back. At that time we didn't have the foldable lenses, or at that time the patient was not available. The foldable lenses were not available at that time. So as you can see here, the lens is hanging in the mid-vitreous cavity. This is the haptics of the PMMA lens. So what are we going to do with this lens? The pupil again is very much dilated, and there are some areas of tissue or iris tissue loss. And as you can see, with the difference of the focus, I'm trying to focus on the lens. The iris is out of focus, and if you are focusing on the iris, the lens becomes out of focus. That denotes how much the lens is tilted in the mid-vitreal cavity. So the plan here is to explant implant this lens. So here I'm trying with the microforceps through one of the parasyntheses, trying to secure this lens before falling down. I'm not a posterior segment surgeon. I'm trying to secure this lens inside the anterior chamber before falling down. It turns that the other haptic was clearly fixated with a Prolene suture, so I had to cut it with the micro scissor through another paracentesis, and then I have to bring this lens as fast as possible inside the anterior chamber. As you can see with the aid of the second instrument, it tends to be very large lens. You can see the haptic are very long, and the optic of the lens was huge, maybe 7 millimeter or sometimes maybe more. This kind of lenses that most probably I never seen before, but as you can see, this is clearly fixated lens designed for scleral fixation by, as you can see, the eyelets of the present on the haptic. So here I'm trying to remove this haptic and the lens from the sulcus, or bring this lens into the anterior chamber, and trying to twist the haptic, do whatever you can to just secure the lens inside the anterior chamber. And finally, I could secure the lens inside the anterior chamber. And now this is time for explantation of the lens. This is another way to explant the lens. This is a 3-piece lens, so we can do either scleral incision with frown incision, but in this case in particular, the patient has with the rule astigmatism of 3 diopters, so why not to remove the lens through a limbal incision, trying to relax the cornea at that steep meridian. So I had to cut one of the haptics with the scissor and then remove the first haptic, and then I can remove the whole lens with the other haptic through the main incision. Again, I just made a limbal incision on purpose, trying to correct some of the astigmatism this patient had. And as you can see, then again, the patient was already vitrectomized because of the congenital cataract or traumatic cataract. I was not sure, but as you can see, you have to stain, because sometimes you may add with some remnant of the vitreous prolapsed into the main incision driven by the pressure gradient. And here I'm just testing because of the quality control of some of the 27 gauge needle in our area. You have to test the if the haptic will go through this 27 gauge needle or not. Just after closing the main incision with a temporary suture, I'm preparing now for the Yamani technique by placing the 27 gauge needle into the posterior chamber of the eye, and then removal of the suture, implant the 3-piece lens without unfolding because we have a large incision, and do the Yamani technique. This is the first haptic to be fed inside the first needle, and this is the second haptic, feeding the second haptic into the second needle. And then we can externalize both haptics and do the flange technique. I cannot leave this patient this way because the pupil is very much dilated, and the patient won't be happy with the dazzling that comes from the edge of the lens. So we have to do something for the pupil for this patient, otherwise the patient will end up with some photophobia. So I had to do some pupilloplasty to bring the pupil down because of the area of the adhesions between the iris and the periphery of the cornea and some of the iris tissue loss. So this is the single pass 4-throw pupilloplasty to bring the pupil down. You can do as many stitches or sutures as you can just to bring the pupil. And this is the moment of truth. You have to select where to put your suture across the pupillary border. And this is now I'm doing 4 throws through the loop of the Prolene 10O on the conjunctival surface. This technique is very simple compared to the other techniques like modified Sips or slipping knot technique. So here, just by pulling the ends of the Prolene 10O, you can bring the pupil down. So we can repeat now the suture. You can just do 2, 3, 4, 5 single pass 4-throw pupilloplasty to bring the pupil down and close the defect. And this is the case just before conclusion of the surgery. And the patient was pretty happy because of the visual outcomes. The best corrected visual acuity is 0.8, and there is no photophobia, and the patient was pleased by the result of the surgery. Thank you very much for your attention.
Thank you very much, Dr. Ahmed Assaf. Last speaker, our Dr. Sami Rabi'a. He will talk about the wavefront guided, topo-guided laser correction and how to treat wavefront aberrations. Thank you very much.
Assalamu alaikum. After heavy dose, I think you have to have something light. We'll start, inshallah. Slides, please. قلنا لايت بس معناها you can start. Any question?
Should we make discussion until the slide started?
Very clear, huh? Flash? Flash now?
Dr. Turki, I have a question regarding IOL calculation in the keratoconus patient. We know if the Kmax is less than 55, it will be easy to capture the beta cam and take other like keratometry captured, take the K value from it. What about if the patient have more than 55 Kmax and it's very like severe to moderate keratoconus, which the formula you recommended in this situation, and what about the K value? Did you take it as like 43.25, or is there any recommendation about it?
I have a couple of cases. Assalamu alaikum. I had a couple of cases of keratoconus. I back calculate them, and I noticed that cane keratoconus is the most accurate. However, if you go beyond 58 or K max, usually you have to go for more myopia, despite using cane, although it is the most accurate. The cane keratoconus, when you go to the website, you will see cane for regular eyes, for toric and keratoconus. The keratoconus is the most accurate, but if the Ks are high, very high, go for more myopia, -1, -1.5.
And if it's below like 55, do you recommend the SRK2 or another formula?
Some will go with SRK, but I think cane is the most accurate. When I back calculate them, cane is very accurate. Cane keratoconus.
Okay.
Because you know what, the K readings, the refractive index of our K readings we are using for the calculation and to measure the K readings is not the accurate one. We have another refractive index, but this one, they just using it to include the posterior corneal surface. Yeah. So in keratoconus or any ectasia, usually this ratio between anterior and posterior is not accurate, and it is not there anymore. That's why even with the K readings, when you see it is 53, the real corneal dioptric power is 58 or 60.
Mm-hmm. What about the post-myopic laser correction or any like refractive?
Yeah, usually I'm using like an Excel sheet. I'm using double K method and compare it to Barrett through K.
Okay.
And usually, if the pentacam is homogeneous, usually it will be very accurate.
Mm-hmm. Yep.
Yes.
Thank you very much. Any questions for any panel for the speakers?
Anyone to ask the previous speakers any question? دكتورة واضحة.
Okay. Can we start?
Start now, yeah.
Bismillah ar-Rahman ar-Rahim. It is selective measuring and correcting the high orders wavefront aberration. Why do we do that? Sometimes you have cases like high astigmatism, high irregular astigmatism in cases of keratoconus or whatever you have, but you have high irregular astigmatism. And then the patient has high myopia, high astigmatism, whatever, but it is irregular. If you are planning to put an ICL, patient will never get 20/20, exactly like a glasses, because there is something which is not correctable by glasses or ICL, which is the high order aberration. So, like in irregular astigmatism, if you change an irregular, it doesn't show up. Okay, if you change irregular astigmatism into regular astigmatism, and then the result will be much, much better if you correct the patient order. And then patient with high order like coma or spherical aberration, and they have very thin tissue, you cannot do anything. So if you just correct these things with a very small correction, with only few microns, you are getting really good achievement without damaging the cornea. And then also, if you have some post-laser complications, something like the coma or spherical aberration, again, you have problems here that you can correct with minimal tissue without too much tissue taken. And also, you can work on normal cornea to induce aberration in order to get him better reading facilities. We'll discuss these. Now, what are the wavefront aberration? Wavefront is the difference between the ideal system, ideal wavefront, and the actual wavefront of that patient. It is either low order that be corrected with glasses, or high order that cannot be corrected with glasses. High order cannot be corrected with glasses. And we should thank this great man, Zerniki, for his way of classification of the high orders. He made it in a pyramid-like, as you can see. It's a, I hope, no, nothing. It's a pyramid-like, and it is in order, 1, 2, 3, 4, 5, 6, you go down, and then on regular frequency, minus and plus, and in the middle is the 0. What does that mean? If it is 3, so there are three aberrations, 4 aberrations, 5 aberrations, and this is the way you go down, and then the 0 is if you go to the first one, which is number 2 here, it is 3, 4, and 5. 3 and 5 are the astigmatism. Number 4 is the sphere, whether it's plus or minus. And then if you go down, you go with the coma and the trefoil and so on. And they divided this way. What's the difference between those on the left, those on the right? Some are cardinal, some are oblique. Cardinal, I mean like that, oblique like that. So this is a beautiful way of distributing these astigmatism. And then we will see now, this is again the same thing, the piston, vertical tilt, horizontal tilt. Number 1 and 2, really, number 0 and 1 are not important to us. They are important to physicists. But we start from the second order aberration, as we said, astigmatism and defocus. Then these are the low order. The number 2 is the low order, and this is the one which is corrected by glasses. So your glasses is only corrected sphere cylinder. That's it. Now from down you go, it starts your high order aberrations. And it is a long way down, going down. But really what's more important to us is the coma, whether horizontal and vertical, number 7 and number 8. Again, spherical aberration, number 12. So 7, 8, and 12 are the most important. Yet, the trefoil, whether it is vertical and oblique, to some extent are important. These are astigmatism, this belongs to the second, astigmatism defocus, and then the 2 vertical coma, and the 2 trefoil, and then spherical aberration down. Secondary astigmatism and trefoil are not that important. Now, how do you measure? You have to measure it first. I myself, I use the OBD scan 3 or the Galilei Schimflong. Anybody of you who has Schimflong can study it. Now, if you look carefully here, everybody will know that this is something like advanced keratoconus, maybe, But if you can divide it, you can look at the coma. The coma is high, 0.57. It's not that high. So it is slightly high. And then look at the total sphere, total spherical aberration. It's not high at all. It is 0.024. And if you look at the trefoil, it's not high. So your main problem there is the coma, which is not that much high. This is the way to study it. Now, if you look to the other one, which was more advanced, look, the coma is higher, the total spherical aberration is higher, and the trefoil is higher. So you have to go and correct more and more of the errors. Each one of these errors is only few microns to correct, and you are going to give the patient good result. Now, if you look at this one, this is what we call the nipple. The nipple here, if this nipple, mainly goes the spherical aberration is getting really high, 1.2, yet the coma is high and the trefoil is high. So this is the way, how do you measure it? This is a normal person, very high astigmatism. Coma, sphere, and trefoil, they are all low numbers. That one, after correction, it looks terrible, the shape. But if you look at the function, all the functions are good. So you're not worried about this one. And this is the other way. This is the Galilei, for example. You can have, there is nothing measured here, but you will ask the machine just for the coma there, and it will you the coma is 1.28, so the coma is high. You don't want the coma. You want to look at the trefoil. Trefoil is still 1.3, very high. And then you may not want this one. You want the spherical aberration. Spherical aberration is low. It's really low here. So the problem is not in the spherical aberration and the others. Now, what are the things that can be corrected with just touch of microns? Astigmatism, as we said, whether regular or irregular, and we'll discuss it, coma, and spherical aberration. Astigmatism, either to convert irregular into regular, or reduce the corneal astigmatism with minimal coupling effect. Any astigmatism, any way you do, you have a coupling effect. But if you don't want to have a coupling effect, maybe you don't have too much tissue, or your refraction does not allow you to have a coupling effect, you can just work on the coma by the wavefront, huh? Not correcting a coma as not correcting astigmatism as astigmatism. Now look at this one. This is here. This is keratoconus. Definitely, he has astigmatism 2.7. You just made correction with 28 micron. You can see. I'm sorry. You can 28 micron. You change it from irregular to regular. It is the same degree, 2.78, 2.8, the same degree of astigmatism, but good quality of astigmatism. This patient, you can give him glasses now. You can give him contact lens, ICL, whatever, but he will have good vision. And only by 28 microns. Again, this patient I did this Monday, okay? High astigmatism, 2.9. But the tissue was thin. This is post-operative somewhere done else. Tissue was thin. I didn't have plenty of tissue to correct the astigmatism. All what I did this, 19 micron. It's only treatment of the coma. If you look there to the Zernike, I selected only the coma. And this is the target, and this is what I have. This second day, you will say it looks ugly. Yes, because it's second day, it's not healing yet. But when you reach it, look at the difference between this astigmatism and that shape, only by 19 micron. And this is it. This is the magnification of the picture. Okay? Now, the coma, what's the coma? Coma is, everybody knows the coma, but there's no time. They give me 10 minutes. It comes in either ectasia or decentered ablation. Spherical aberration, either post-myopic, and we will discuss it, or we said we are inducing more negative or increasing the negative asphericity or reducing the positive asphericity and to increase the depth of focus. This is one way of treating presbyopia. Now, if you look carefully to this patient, he definitely has decentered treatment, so he has coma. Also with the coma, he has high spherical aberration, high spherical. So he has spherical as well as coma. I did not treat anything. Look at, it is just empty, nothing treated. Now, treating, if you look carefully there, all what I did the coma and spherical aberration. 17 micron. Look at the difference in the shape from this one to this one. Astigmatism, there was no astigmatism, but the quality of vision is really improving only by 17.9 micron. Now, what's spherical aberration? Spherical aberration, everybody knows, maybe, but this is for the slight junior stuff. Spherical aberration, if we have a cornea that is completely rounded, the light at the periphery will not be reflected like the light in the center. The light in the periphery will go, the more you go to the periphery, the more light is cut forward. And instead of reaching to the retina, it goes, if you go that way, it goes forward, up, up, up. And the way it goes up, we call it the positive. If it goes down, we call it negative. So if I say positive spherical aberration, means it goes up, okay? So, but God, alhamdulillah, did not make our cornea like that. We have a prolate cornea that the more we go at the periphery, it gets flatter, 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 flatter. And this ensures that the light, the more it goes out of the center, it goes down to reach the zero. Okay, it is not zero, but just I'm trying to explain to you that the light goes hopefully to the center, and this is the normal person. And if you look at this is post myopic correction, flatten the center. Look at the periphery. Periphery becomes steep. Then the flat, which we are happy with, becomes steep, and the light that goes down now will be up. So positive aberration will be high after myopic correction. On the contrary, this is a patient who underwent hyperopic correction, and the periphery will be flat. So this flat will be more flat, and the negative and the positive sphericity will be less sphericity. It will go down. You may be happy, you say this is very good to go down. No, because it's not only the cornea which we have, our system, we have the cornea, we have peripheral lens. Both together, they push it down. So don't rely on one subject, which is the cornea, otherwise we'll go really much down. Now, okay, this is just to make it simple. This is if we have spherical cornea, and the light will be closed, very high spheric positive, but we have cornea that is tilted, it is prolate, and the light goes down, so it is less positive spherical aberration. Once you have the lens there, the lens also add more, and it goes down to the zero, almost zero. It's not zero, it's 0.1, almost zero. And then if we do correction, if we do myopic correction, it goes higher up. If we do hyperopic correction, it goes down. These are the problems. Now, how we induce? If you have a patient and he is about 50 and you want to do his cataract, you can do his what we call extended depth of vision in one eye. And we will show you that by increasing only the spherical. You correct everything. One eye you make it for distance, other eye I just make it about -1. So for reading, but in the -1 I play around with the spherical aberration. So I give him big depth of focus, and the -1 will be very happy. He could read and enjoy distance. So we will show that. So the idea is to increase. This is a hyperopic patient. You can see from the correction. He was 39.9, become 42, yani about 2 diopters correction. And this is only correction for hyperopia with some astigmatism. +3 and +1.3, +1.9. Okay? Now, look at the spherical aberration after this treatment. It from 0.24 become 0.81. Yes, increased. I didn't touch the spherical aberration yet. Now, look at this one and look at this one. Back again, in the center, the spherical one. I just corrected the spherical, and look at this one. From 81, become 245. So really, I increased the depth. Just by how much? By 10 microns. So only by 10 microns, I gave him a good depth of vision for him to read. And now, this is myopic correction. Again, look at it. From 38, become 36. Nice, nothing is done there. Once I corrected, only by 13 micron, I gave him much better. Look at the Q value. Q value here was 0.7, become -1.4, at 4 millimeters, and then the one reduced to 0.2. So I'm reducing the positive sphericity, positive spherical aberration to give him better depth of focus, whether myope or hyperope. And that's it. This is the same eye. And this is the same eye. And this is not done. This is just to show you. If I'm going, this is 44.4. Suppose this patient is plus 3.5 plus 4. So one eye, look at it, 40. 40 or 44 يعني تصلح 4 degrees hyperopia corrected. Myopia corrected there. This one 42. So if I'm going to do myopia correction, I undercorrect. Not 40, 42. معناها still some myopia. And then look at the treatment. That treatment is 7 millimeters to 9 millimeters. This one is smaller, 5 to 7. So I'm giving him smaller treatment than if I'm planning for depth. And then look at the spherical aberration. I increase the spherical become, in this 50 compared to the other one. Now, if you look at the spherical aberration, 0.39 here, but if you look there, number 12, it's 0.65. Look at this, this is 300, this is 69. So really it's much more if you do this technique, only by few microns, presbyopia correction. The technique, you select this patient without any treatment. He has, look at the error, 2.6. He has a really high error. And then we try to correct trefoil only, okay? Trefoil, 8 microns, from 2.6, 2.3, not too much, not too much. And then look at the coma from 2.1 become 0.7. So really the coma is 3 times improving. Now, look at the screen there. This is before treatment, and this is only the trefoil, and here the coma. You see the coma? Only added few points. So only by adding few points, I corrected the coma and the trefoil. By 41 micron, these are improving. And look at the total high order, 2.6 becoming 1.5. Very good. But the total is not really improving. It is 10 becoming 6. Yes, I corrected the 4 that not corrected by glasses. I left 6 because I don't have enough tissue. So trefoil coma is still low order there. So the main concern is the quality of vision. There is no enough tissue. If I have enough tissue, I could have gone to correct the sphere and cylinder. But I don't have it. I corrected the things that will give him better vision. Again, the same one, 41. So this is the same patient. This is the same patient. If we said we just corrected the error, we left the tissue. Now, look at RMS. What is the RMS? RMS is the root mean square. And if you look carefully here, there's root mean square value at 3 millimeters and 5 millimeters. Root mean square value, it tells you how far is the bad this eye. Okay, the total quality of the eye. The higher the square mean value, the less the quality. The best is something like 0.4, 0.3. So he was 3.6 becoming 0.9 at 3 millimeters. At 5 millimeters, he was 3.6 again, becoming 1.9. So you really improve the quality, not the shape. The shape is not too much, but the quality is improving by only 41 microns, by just touching. Better quality of vision. Walhamdulillah Rabbil Alameen. I hope you enjoyed it.
Thank you very much. Any question from the audience? Dr. Rabia, which platform you are using here and explain? Is it which platform?
I'm using the NIDIC.
Yes.
Yes.
NIDIC.
It is NIDIC Final Fit.
Yeah.
Where you can select each one. It is OBD3 scan. I select whatever I want, and I just go for this. You don't believe it's only 15 micron. It is 2 or 3 seconds, and that's it. Patients, a few days later, the quality is different.
Yeah.
Yes?
Thank you very much for the nice presentation. I have no experience with
It is OBD3 scan. It is not Hartmann-Shack. it is retinoscopy. OBD.
And my question, how do you see the tracking system? I think, yeah, thank you very much. I think it's really very well demonstrated that we can do so much with high order aberration, addressing high order aberrations, but still I think the technology is lacking because tear film is dynamic, and when we do the measurement, patient is sitting, the tear film is different. When we do the surgery, the tear film comes out of the way, 1. 2, the epithelium, now more and more platforms are integrating the epithelial map into the equation, because definitely we are treating it as one.
Beautiful. Epithelial map goes for not here.
And the last thing I want to say, that a tracking system cannot keep up with what we are intending to address. Yes, we do have good effect, but I think we are still very far technology-wise from being perfect in addressing all high-order aberrations. That's my simple opinion in the whole issue.
Thank you, Ahmed. I don't want to make a statement for Nidek, okay? That old man, old horse, but really it's the very strong horse. Tracking is excellent. Astigmatism correction, tracking, and fixation with the eye. It's an absolute system that I don't know why it's not so much known, but it is a beautiful system. And we do have good tracking. Regarding the epithelium, epithelium is okay. This epithelium comes, I think maybe in the next lecture. Epithelium comes with problems that it is in shape, because epithelium tries to correct the shape of the cornea. And that's why it has an importance. Spherical aberrations and these things like astigmatism and so on, really epithelium has no role in it. That's why you can do it even under the flap, or you can just remove the epithelium manually and do it. It's not like the customized topography guided treatment. And I think I have a touch on it on the next lecture, but customized topography guided, here the epithelium plays a role in the astigmatism, and the degree of astigmatism, and the access with astigmatism, and the K readings. So epithelium really it's a friend to cover, but it's an enemy to hide.
Yeah, it's not the regular astigmatism straightforward case. I'm talking about irregular surfaces trying to regularize it. Yes. In the straightforward cases, generally the epithelium will not have lots of role because it will be homogeneous thickness across the board. But when it's irregular, like pellucid, keratoconus, irregular cornea, irregular astigmatism, if you had a treatment with a central island, all of those will give you discrepancy in the stromal thickness, which will result in discrepancy in how much the...
Absolutely right.
Yeah. So it is important.
If the shape is different, yes, you think about it. Okay. Sometimes irregular astigmatism has nothing to the shape, but I showed you that slide. They could have give me the topography because there will be two. Next talk. Should I start? Start, please. Next talk is about the difference between topography guided and wavefront guided. We have to know that topography guided is not wavefront. Wavefront, it goes through the pupil. Wavefront, it takes the aberrations of the eye. But topography guided is the shape. Topography guided is something different. Now, Bismillah ar-Rahman ar-Rahim. Customized treatment, and from customized we'll talk about the two types. It is to apply laser treatment on the cornea, not aiming for refractive error correction. It is either for irregular or regular cornea. And why customized? Because if you use plain PTK, plain treatment, the energy distribution is equal on all the parts of the surface of the cornea. And every part of the cornea will take the same energy, and it will be removed exactly on this side, like that side. So all what we have the same surface, replicated or duplicated. It just goes down. It is the same shape. This is if you have plain PTK. But if plain treatment, but if you have customized treatment, the energy will be directed to the area where you want to treat, and there is no energy to the area that you don't want to treat. And this is the difference between the customized treatment and non-customized treatment. And here, the rule, this comes with what I said in the previous lecture. Now we will talk again. Now, it is to treat either irregular cornea, so we are talking about the shape, or irregular function, and we are talking about wavefront. Function is not the shape. That's why I'm not really affected too much by the epithelium. So it's either irregular shape or irregular function, or irregular cornea to irregular cornea. And keep in mind, not all abnormalities should be treated, because you may have an abnormality on the surface of the cornea that already corrected by the back surface, posterior part of the cornea is correcting the anterior part of the cornea, or by the lens or the vitreous, whatever. The total error is nothing. Something is correcting. But what you see in front of you, try to correct it, you end up with another problem behind. They are neutralizing themselves, so don't try to correct them. Something which I didn't mention here, if you have astigmatism with the rule, and then if you look at the coma is vertical. Don't try to correct the coma, because the coma is correcting the astigmatism with the rule. And you see the astigmatism with the rule in the topography, but once you do refraction, it is zero. How comes that? Because he has coma that correcting. So don't try to go and correct the coma because it's high. Coma is doing the job. So don't correct everything. And then you have to know that if you change the shape, also you will change the function. So these two things important. Now this is the shape. What is this? This is the abnormal shape. In the center you have a normal shape, the distribution, look at the smooth distribution of colors, and then the symmetry up and down, or right and left. But if you have different colors, different shapes, and there is no symmetry, so this is what we call the shape. And so shape topography, the color, the K value difference, high K value, valleys are down, hills are high, and symmetry is lost. This is shape. What about the function? The function, they look all good. They are all bottles in your kitchen, but one of them, your wife maybe put cyanide. Take care. There is vinegar, lemon, whatever, but there is one cyanide. So the function is different from the shape. Take care of that. And that's why the epithelium doesn't go here. Here, the epithelium has no role. Now, the function is measured by wavefront aberration, and we said it is the difference between the patient's wavefront and the actual or excellent vision of perfect patient. This is how to measure. And we said low order.